Okay, now let's start. So today I'll talk about arithmetic HKA. So arithmetic HKA is very important in current TK technique such as kinematic alignment because arithmetic HKA displays the patient native alignment, especially the global alignment. That is expressed as HKA. But normally HKA includes like this. So this is a native HKA. That when the patient has intact cartilage, so femoral and tibial joint lines are parallel to each other. So the HKA in this situation means the patient native or constitutional HKA. On the other hand, if the patient has arthritis, the medial cartilage has gone. So joint line or the femur and tibia are not parallel to each other, and it forms joint line convergence angle, so-called JLCA. JLCA expresses the degree of cartilage wear. So in the HKA in OA patient, so this HKA, so-called mechanical HKA, means includes native HKA plus JLCA. But if the patient doesn't have bone defect, not cartilage defect, or bone defect, so MPTA and LDFA is same, almost same when he has intact cartilage. ちょっと入ってはるから外れてんの。So that's a key point. LDFA, MPTA never change as long as there is no bone defect. Only the cartilage will makes JLCA, but never changed LDFA and MPTA. So if we calculate MPTA minus LDFA, it is almost same as the patient constitutional HKA. In other words, if we calculate MPTA minus LDFA, we can know the patient native leg alignment, leg global alignment. Okay? You know, MPTA minus HKA. But if MPTA is larger than LDFA, arithmetic HK comes minus value. It means minus value means valves are minus. If the MPTA is larger than LDFA, it means the patient has valgus HK. Okay? If the same, the parallel. This is so-called mechanical alignment, neutral alignment. Okay. Even if the patient has cartilage wear in the medial side, in the OA, the patient MPTA equal LDFA, the patient native alignment should be neutral. But actually, so mechanical HKA, so that means the simple calculation between the femoral mechanical alignment and the tibial mechanical alignment. If it is HKA is minus value, the patient has a native, so neutral alignment. わかる言ってること。仮にこことここ等しくて全くまっすぐな人でもさ、軟骨がなくなったら見かけ上は内反になってくるわけ。でも、この人本来は MPTA と LDFA が一緒やったら、本来はこの人の足はまっすぐなはずですよ。でも、軟骨がなくなってるから、OA に見えてるだけで、これを矯正してあげたら、本来のものになる。で、矯正までせんでも、just calculate MPTA minus L. We can estimate patient native HK, hip, knee, ankle. Okay? So, why it is so important? The one is that we can know the patient native HKA, the patient native global recurrent. Okay? This is the one. The second one is that we can estimate this JLCA is successfully corrected by operation, such as UK or HKA. HKA is a kinematic alignment because kinematic alignment HKA aims for restore the patient native joint line. Okay, so sorry. So using arithmetic HKA, MPTA minus LDFA, we can estimate post-operative alignment after kinematic alignment. But mechanical alignment TK, we don't have to care about the patient native anatomy, patient native alignment. Just disrupt or reconstruct the patient leg to be neutral. もうどんなに曲がってようがどんなんでもまっすぐにするというのがあるから、本来のこれっていうのはもう全く関係ない。で、we should apply 19 degrees of MPTA and 19 degrees of LDFA in all patients, regardless the patient native anatomy or variety. But in kinematic alignment TK, we should respect the patient native joint line, patient native alignment, and patient native soft tissue balance. So just the aim of the kinematic alignment is just restore the patient native joint line. So we can estimate the patient post-operative alignment after kinematic alignment. Of course, we can easily estimate after mechanical alignment again. 0 degrees HKA and 19 degree MPTA, 90 degree L. That's all. So this is the one paper from McTessie. McTessie is first reported about kinematic arithmetic HKA and CPAC classification. He's a very famous Australian doctor. So he compared the normal knees and arthritic knees. Compare. This distribution is almost same. So this is the one proof of if we can calculate arithmetic HKA, we can estimate the patient constitutional HKA. Again, why we should know the constitutional HKA? No, this is still under discussion. We can naively follow the patient native HKA, or we should restrict it. If the patient has both, look, this is 10 degrees in the valgus and 10 degrees in pars. If the patient has 8 degrees on pars, we don't know, we can follow the patient native alignment, 80 degrees. Or we should avoid up to 5 degrees or 3 degrees. This is under controversial. Some doctors, such as Steve Howell, he is the innovator of kinematic alignment. It doesn't matter, just for the patient native anatomy. Because it is the most natural situation of their needs. But another group, such as Professor Bendetori, is a Canadian doctor in Vancouver. He proposed the restricted kinematic alignment. So they restricted the total HKA from 5 degrees varus to 3 degrees of varus. And in terms of HKA and LDFA, plus minus 5 degrees. We called this range is the safe range. And this border is called as boundary. But this safe zone and boundary are quite different among the surgeons. So there is no boundaries based on the evidence. There is no evidence-based boundaries so far. Oh, that is a problem. So therefore, there is under controversial. Another item is joint line obliquity. That is calculated as MPTA plus LDFA. If the patient has the straight leg, it most easily understood. If MPTA minus LDFA is less than 180 degrees, it implies medially inclined joint line. Okay. If MPTA plus LDFA is 180 degrees, the joint line should be neutral. And more than 100 degrees is laterally inclined, so-called apex proximal. This is the neutral. This is apex distal. 頂点が下ね。これは頂点が。Then express categorized into 3 categories: apex distal, neutral, and apex proximal. Easily categorized, but I don't know what does the JLO means so far. But another joint line obliquity exists. One is the joint line orientation angle. The joint line orientation angle is angle between the floor and the joint line. This joint line is sometimes misunderstood as joint line orientation angle, JLOA. JLOA means if the JLOA is 0 degrees, it means the joint line is parallel to the floor. So if we do the mechanical alignment TKA, joint line is always perpendicular to the axis. But in most patients, leg incline internally like this, not like this, like this. As a result, postoperative joint line orientation comes laterally inclined. But after kinematic alignment, joint line comes almost parallel to the floor. But this JLO is a little different measurement than JLOA. ちょっとよく混乱するかもしれないけど、もう一つこのジョイントラインの示し方があって、それは床面に対して平行か内側かっていうことなね。それもよく使われます。でも、ここで言うてるのはあくまでこれとこれと足して、それがどうなるかっていうことね。もう、まっすぐやったら想像できやすいけど、これが内反しとったら、ちょっと解釈が難しくなるので、まだちょっと未だに僕自身はあんまり理解できてない。 どこまでこの意味があるのかなっていうのはちょっと理解してないんだけども、まあ、世間的にはこれやね、もう非常に有名なシールバック分類ですね。Arithmetic aHKA, this means the global like alignment and joint line of equity in the inclination of joint line and categorized into nine categories. 1, 2, 3, 4, 5, 6, 7, 8, 9. And this is the varus apex distance. After kinematic alignment, CPAC classification never change, ideally. And because we can respect the patient's leg alignment and joint line. After mechanical alignment, all patients comes to class type 5. After restricted kinematic alignment, the distribution comes slightly concentrated to the type 5, but slightly smaller in 1, 2, 3, 4, 6, 7, 8, 9. まあ、全体的にこっちの方にちょっと集中して、まあ、この割合はちょっと周辺の割合は少なくなるかなというところです。っていうことが、もう、まあ、この前も学会でちょっと聞いたから分かるんだけど、もうかなり出てくるね、心拍っていう。まあ、だからそれだけ、なんでこれだけ注目されるかというか、それだけ、その人それぞれのアライメントの特徴をよく考慮して治療しましょうという、あの、の方向に来てるということと、やっぱり自分がどこを目指してやってるかっていうのをより明確にしましょうという方向に来てますよと。